This is the Avalanche. The Avalanche was at the TCT. I was actually at the TCT in San Francisco, and the Absorb took a big type of attention TCT 2015. Let me just start with this quotation from Dr. Dean Kyriakis, who is the PI of the Absorb 3 trial, which was presented here. It says conventional stents, including the best in the class, they have a 5-year target lesion failure, which is 17%. And approximately half of this is attributed to the metal stent inside the artery. But he says also there is only one way for the metallic scaffold to respond over time, and that's to become narrower. The Absorb BVS كلكم تعرفوا عنها مش جاي أنا أحكي لكم عنها of course, but it's made of polylactate زي الabsorbable sutures تبعت surgeons, and it still will give you illusion of everolimus. It's like, a drug-eluting stent, of course, it gives you the medication too. The Absorb First study was presented, that's one of them. The Absorb First was presented as a 1-year follow-up. It's a global registry which looked at real-life patients and were followed up for 1 year. I'm not going to dwell on the studies in detail. We were part of the study. You can see that Jordan was put over here. I actually was the primary and still the primary investigator at Amman Surgical Hospital, and I managed to recruit 37 patients for the study, which accumulated almost 2,000 patients. And I was actually honored to be one of the top 20 recruiters amongst 90 centers global-wise in the study, which was pointed out at the TCT presentation. Now, one thing I wanted just to go through that, which is important, that the lesions which were treated, most of them were complex. And they were approached by radial approach in 56% of the cases. Like all the Absorb studies compared to Science V, but this is not compared to Science V, this is just a registry of the Absorb. You can look at the in-hospital and the 1-year events. They are relatively low and comparable to what we have from the Science V and the best-in-class DESs. You look at the ischemia-driven TLR, of course it's not in the hospital. At 1 year, it's only 1.5%. Relatively low. The target lesion failure, 2.4%, whether it is device oriented composite endpoint or patient-oriented composite endpoint. It's very low relatively and acceptable. What we find in that registry, the predictors of target lesion failure, they seem to be diabetes and of course long lesions if you use overlap Absorb to cover those long lesions. Acute and subacute and late stent thrombosis seem to be very low, at least in the Absorb registry, Absorb First registry which we have. It's extremely low comparable to all what we have. So what was the conclusion of the study? The safety and the effectiveness of the Absorb BVS demonstrated in multiple earlier trials with simpler lesions was also demonstrated in this study. It stressed very importantly when they looked at the post hoc analysis, the adequate lesion pre-dilatation, the appropriate device to vessel sizing, and the high pressure post-dilatation. I think these 3 important points, I think they have to be in the brain of everybody who really uses the Absorb on a day-to-day basis. In the TCT, the Absorb 3 was a well-weighted study لأنه الكل كان عم يستناها for the FDA approval. Dean Kyriakis presented the Absorb 3 study, which recruited 2,000 patients in the US and Australia in 2-to-1 fashion, and they followed them up to 12 months, and they are planning on following them up to 5 years. I just picked some of the slides which might interest you about the Absorb 3. One thing I want you to remember that 1/3 of the patients were diabetic, but they were actually having relatively simple lesions. They are not really complex lesions. Look at this here, that the US physicians, because they were still early with the Absorb, only 2/3 of them used post-dilatation. And I'm telling you, these days, if you use Absorb, you must use post-dilatation in 100% of the patients, unless there's any technical difficulty which doesn't make you do that. في ناس كثير اكيد بالاودينس قاعدين استعملوا الابسورب بقول لك والله بتاخذ وقت اطول. Look at the 2,000 patients. It took only 4 minutes extra time in the cath lab to perform it in the right fashion. So it's not really a matter of a lengthy procedure. 4 minutes is not a big deal. The Absorb 3 again, like most of the other studies, the Absorb 1 and 2, the target lesion failure was comparable. It was not, it reached the non-inferiority line. And when they looked at the device thrombosis at 1 year, comparing Absorb and Xience, again the p-value was negligible. And you look at the numbers, they are really comparable. When you look at the early 0 to 30 days, you can see a bit of a trend of increased Absorb. It's actually, I wanted to spend 1 second about this. A lot of the data which come out of the Absorb are showing a bit of an increase of device with scaffold thrombosis in the first 4 weeks. It tells you 2 things. It's probably operator dependent. It's not the Absorb itself. Most likely, it's operator dependent, the way it was done, post-dilatation, sizing, and you name it. And there's one other issue which I want also to enlighten you about, which was hot in the meeting. Maybe in the Absorb, maybe, you probably don't have to use Plavix in the first month. You probably can use ticagrelor and nashipasugal with the aspirin because of the little bit of the incidence of in the first 4 weeks. When they looked at powered secondary endpoints, angina, or revascularization, ischemia-driven TVR, again, they were comparable. So it proved beyond doubt that it's non-inferior to the Xience V. الإشي المهم هنا برضه هذا مهم إن اللي بنستعمل الأبصار. When they looked at the reference diameter of the vessel, which is below 2.25, it did not do well, and the Xience V did not do well. What does that mean? That doesn't mean that they are both bad. That means that in the smaller vessels, if you put an Absorb, the target lesion failure is very high, as well as the Xience V, and the stent thrombosis is high compared to the above 2.25. And with that comes the recommendation: if you have to do it in small vessels, must do an IVUS to make sure what the size of the vessel is and to make sure that you are doing it properly. Conclusion, again, it's a non-inferior scaffold. You can call it a stent, I call it a scaffold, compared to the Xience V, which they called in the meeting the best in its class available as a DES. One thing I want you to remember that these patients, which they have stabilized ACS patients, but they did not include any acute coronary syndrome. The other study which was also presented was by Greg Stone. He did a beautiful meta-analysis on all the Absorb data which is available to us until now. What did it show? The same thing here. It's non-inferior to the cobalt-chrome Xience V in terms of patient-oriented composite endpoint or device-oriented composite endpoint. It's same numbers. Maybe there's a bit of trend of a higher number, but it's not of any p-value to consider statistically. And when they looked at the stent thrombosis in the scaffold thrombosis compared to the DES, definite, probable, early, and late. Again, there was none p-value significance of increased scaffold thrombosis, but again, please keep your eye on this. Please keep your eye on how you do it in the cath lab, how to perfect it, how to prep the region, and in my humble opinion, I would just use ticagrelor and aspirin for the first month, irrespective in those particular patients. Now, with the 1 year meta-analysis, again, that's from Greg Stone, there was no significant difference in peri-procedural MI, but was a small increase in the target vessel MI in the Absorb, especially in the patients in the early stage. هذا الشيء الانترستينج باتريك سيرايز اللي كلكم تعرفوه أكيد يعني. He's somebody who scientific wise nobody can doubt, I'm sure. He looked at 5 years follow-up in the first patients they did in Rotterdam with BVS, and they did OCT in some of the patients. And he presented this year. What you're seeing here, that on the left side here and on the bottom, they're looking at the months here. When you look at the dotted line, this is the mean minimum scaffold area. You can see that you put it here and it starts going up. The lumen area on follow-up, it stays stable. The neo-intima at 5 years, it's actually gone. And you can see the media and the intima itself. هدول البوكسز اللي بالنص بالوول هم هدول البوكسز تبعين الابسورب early on which are not completely resolved, and here they are gone at 5 years. And what he showed nicely also in that OCT, you can see that the plaque area significantly decreased, and you can see clearly on patients who had the absorbed, the media very nicely, and the intima very nicely, and there's no neo type of intima like what we see with the metal stents. لما نحط احنا الابسورب هذا بالاو سي تي ان شاء الله بنصير عندنا soon, you can see the boxes here separated. On follow-up at 6 months, they become endothelialized. You can see the box, endothelium, the boxes, endothelium, and so forth. And at 2 years, some of them are gone, and some of them are about to go, and they are all engulfed within the endothelialized intima here. So what did Badix-Rice conclude? That the absorb gives us a stable lumen dimension, and if you compare it to the Zions implantation, which shows moderate but continuous reduction in the stented lumen. You better believe it. If you do OCT for your patients, who you put metal in the arteries, if you continue to do that, there will be a shrinkage in the lumen as you follow them up. And the large majority of the scaffold segments, above 80%, they exhibited vasodilatation post-nitrate. بمعنى إنه the functionality of the segment اللي بتحط فيها الستنت, it comes back, which is wonderful. يعني أنت معظمنا بيعرف إنك إذا حطيت ستنت metal بالsegment you give sublingual nitro, most likely that particular segment is not going to respond to that. But the absorb, when it goes away, they work. Bernard Cavalier, عمري ما قعدت أحكي اسمه هذا الزلمة. But anyways, he presented the absorb 2. I did not want to put it here. The absorb 2 at 2 years follow-up, because it was presented the 1 year follow-up last year. The absorb 2 showed exactly the same as any other study, that the absorb is non-inferior to the Zions V. It's almost the same in your hand. It's not superior, but it's not inferior. But I want to leave you with this quote. The potential benefit you can expect from this technology will take place after the full absorption of the device. فإحنا مستعجلين شوية يا جماعة device. كل واحد بده يشوف superiority. It's not going to show now. The data at 1 and 2 years remain very reassuring because it's very non-inferior. And we expect to see a benefit of the vanishing scaffolds at 3 years and beyond. And I want you to be left with this message. It is too early to judge it in terms of superiority. The bottom line about it, if you have something which is non-inferior to the one which you used every day, so why in the world you would not think about putting something which goes away? Yeah, and I like the quotation of one of the cardiologists who puts the absorb that, well, it's not superior, but it's wonderful not to see the device again after all. So thank you very much. This is my last slide. But let me show you that this one, Abu Sheikha supplied me with this slide. بس عشان أفرجيكم البنتريشن عندنا بالمملكة هاي بيهمك هذا إياه. It's about 5%. It's a bit low, but most of the countries which are starting, they're about 10-15% at least. عندنا في عمان في المملكة ركبنا 766. في العالم كله صار مركب 110,000 device. هذا until the TCT time, I don't know how it is now. And the Absorb 4, which is ongoing now, which they expect they will present it next year too. It might even elaborate further on the Absorb. Thank you very much.